Hello and welcome to this Lancet webinar on context and culture in mental health. We're very excited to have you here with us today. I'm one of your co-hosts. My name's Sophia Davis and I'm senior editor at Lancet Psychiatry. And for some context on me, I'm from the UK where I live now, although I spent a decade living in Germany until quite recently. My background's in history and philosophy of science, and I'm also a somatic therapist, focusing mainly on trauma. So our webinar today on this World Mental Health Day is part of a series of events that's been going on throughout the whole year because 2023 is the 200th anniversary of the Lancet. And across the year, we've been doing webinars, podcasts, and all sorts on 5 topics that we see as important within the history of the Lancet and also that continue to be crucial today. So these 5 themes that we want to spotlight, as well as mental health, are child and adolescent health, health and climate change, research for health, and universal health coverage. But today, mental health is our focus, and our wonderful group of panelists today are going to be discussing the importance of local and indigenous understandings and initiatives within mental health. I was inspired to give a platform to this topic after hearing some of today's panelists speak on these themes in a conference last year, as well as my own long-standing interest in multiple perspectives on mental health and in the history of psychiatry. But before we dive into the topic, we do have a few general points that I've put up on the screen there. So the main thing is, if you want to ask a question, which we would love, you can use the Ask a Question box on the dashboard. You can move all these boxes around on your screen. There's another box that's for Lancet 200 resources. You can use that to go to our webpage and explore. And then finally, after the webinar, you'll receive an email with the link to the on-demand version if you want to share it with someone. And we'll send you a very quick survey to get your feedback. So let's get on with it. I will hand over to my co-host, Anna.
Thank you so much, Soph. So I'm Anna Mateus. I'm an executive editor at the Lancet. I did biomedical research for 10 years before becoming an editor, and I'm particularly interested in population health, including mental health. And as a Portuguese immigrant living in the UK, I have also experienced firsthand the need for context in therapy and mental health care. This is the agenda for today's webinar. So first, our panelists will briefly introduce themselves, and then we'll have 3 questions to be answered by all of them. After this section, we'll open the floor to questions from the audience. So please send us your questions through the webinar platform, as Soph has just explained. And then at the end, Soph will make the concluding remarks. So just to introduce a bit more the topic in detail, psychiatry has been dominated by Western concepts which can miss the sociocultural, religious, and spiritual aspects of some communities. However, these aspects are important to understand individuals' ways of being themselves in relation to the community and the world around them. And this is what we'll focus on today. So we have speakers from different regions of the world and communities to share their local perspectives on mental health. So without further ado, I would like to ask the panelists to introduce themselves following the order presented on the slides. So we start with Camille.
Hello, everybody. My name is Dr. Camille Rupp-Stewart. I'm an Aboriginal woman from Australia. I'm a cross-cultural researcher and a senior lecturer at Monash University. I'm not a psychologist. I'm not psychiatry trained. Rather, my research and teaching focuses on the social and emotional well-being of Aboriginal youth, centering the voices of young people and supporting connection and strong identities to improve well-being more from a social sciences perspective, but bringing in an Indigenous psychology perspective as well. I also lead a specific Indigenous psychology group which supports and mentors other young Indigenous psychology students. I'm a mum, I'm a wife, I'm a daughter, sister, community member. I'm also a disabled woman, so I regularly advocate for greater accessibility and inclusion across a range of intersectional issues. And I think that that kind of a perspective is something that we are seeing to be more and more important in these kinds of conversations. So that's me.
Much, Kami. I think we now move to Naheem.
Hey everyone, happy World Mental Health Day to you all. My name is Naeem Dalal. I'm a medical doctor by training. I'm born and bred third generation in Zambia, in the heart of Central Africa, bordering Southern Africa as well. So my background is that in medicine, and then later on did Masters of Medicine in Psychiatry, and further went on to do a Masters in Youth Mental Health as well. The background that I have in addition to that is experience as a youth mental health advocate with lived experience and caring for people living with mental ill health in my family as well as in my community. In addition to that, I've had been privileged to be in advisories and boards for the past decade, promoting lived experience from the perspective not just of treatment, but also looking at care for care providers as well. So I bring an intersection of all of these, and currently I am stationed at national level supporting policies at the Zambia National Public Health Institute, but I also give advisory to the Africa CDC, and I'm happy to be here. Thank you.
Thank you so much, Naeem. We can now move to Mario.
Delighted to be here in this wonderful meeting. I'm the first Inca physician in South America, and I devoted my life to see patients, to teach, and to do research with the indigenous peoples in South America. I specialize in transcultural psychiatry and in pain medicine. I worked for many reasons, professional reasons. I worked in the US. I held 2 professorships there in the USA. And my training is quite multidisciplinary. And I did this because I wanted to better understand the mental health of the indigenous people. So my training is in the social sciences with a master's in transcultural psychiatry, but also in biomedical science. My PhD is in biomedical sciences. Now I'm working with indigenous people in different projects in the Andean region. And currently, I'm the director of the Runa Jambi Institute, an institute that is devoted to develop personalized medicine for the indigenous peoples of the Americas. Thanks.
Thank you so much, Mario. We can now move to Raj.
Hello, everyone. I'm Raj, and I'm the director of Mariwala Health Initiative, which is an advocacy, capacity building, and grant-making organization that focuses on accessible mental health for historically marginalized communities in India. And I use the lens of lived experience, particularly being neurodivergent and non-binary, to inform my work and my organization's work across 24 different states and 15 languages in India, as well as some of our advocacy work, which is on queer, trans, affirmative mental health. And I'm also on the board of the Indian National Center for Promotion of Employment for Disabled People in India.
Thank you so much, Raj. And finally, we have Victoria.
OCO. Hello, my name is Victoria O'Keefe. I'm Cherokee Nation and Seminole Nation, two tribal nations in Oklahoma here in the United States. I'm the Santoshem Endowed Chair in Native American Health at Johns Hopkins University, where I'm also an assistant professor at the Johns Hopkins Bloomberg School of Public Health, and I'm an associate director at the Johns Hopkins Center for Indigenous Health. I am a clinical psychologist by training, even though I'm now in a school of public health. And my research and public health practice really focuses on Indigenous cultural strengths-based approaches to mental health promotion and suicide prevention. And my community and cultural values as a Cherokee and Seminole woman were passed down to me by the women in my family, especially my grandmother and my mother. And that's really what motivates my work. And I'm really excited to be here. Thanks for having me.
Thank you so much. We are very pleased to have you all participating in this webinar. So now we can move into the first question. So I would just like to say that at the end of each round of questions, the panelists will have the opportunity to comment on previous interventions if they want to. So to kick us off, it would be useful to get a picture of the current situation of well-being, mental health, or mental illness within your communities. So we can start with Cami.
Thank you, Anna. Before I start, one of the things we do within Aboriginal and Torres Strait Islander community is acknowledge and pay respects to our elders and the country that we live and work on. So I would like to pay respects to my elders, people from the Wurundjeri Nation, and pay respects to the traditional owners down here on Wurundjeri country in southern Victoria. The current situation in my community in terms of wellbeing, mental health or mental illness is tenuous, to say the least. I might be approaching this different to some of the other presenters because right now, in 4 days, in fact, we in Australia are having a national referendum on an advisory body called The Voice for Aboriginal and Torres Strait Islander peoples. The idea is to put this advisory body within our constitution, and so that it cannot be eliminated, you know, through future governments. And so that is the current status of what is happening in terms of context. But in terms of specific mental health, I think we can all agree that something like a national referendum where the entire population of Australia has the opportunity to vote on the rights of Indigenous peoples obviously has a huge impact on mental health. We have a population percentage of about 3.84% of Australian population is Aboriginal and or Torres Strait Islander, with the rest being non-Indigenous to Australia, which means there are about 96% of the population voting on the rights of about 4% of people. The discussion in the media right now is pretty horrific. There is a lot of racism, there's a lot of misinformation. The idea and the proposal that has been put forward is not ideal, and there is a lot of division within Indigenous communities about the best way forward. And there is huge amounts of increased racism online, in the streets, in media. And so I think this is the kind of thing that we're thinking about when we talk about what is the context and the culture within our countries. Things like politics can have a huge impact. And in Australia, we were invaded and colonised about 200 years ago, and our mental health and our broader wellbeing has been terrible since then. And we hold the unfortunate status of having some of the highest rates of Indigenous people suiciding in the world. In fact, I think currently our young male Indigenous population has the highest proportion of Indigenous of suicides, full stop. And then in comparison to our non-Indigenous population, there are high levels of psychological distress, a whole range of other social determinants as well. We have things like a lot of removals of children. We have a lower, by about 8 years, a lower length of life. And we currently have about 25% of Indigenous Australians living with a mental health condition. So it's not great. But one of the things that we are seeing right now is a move towards self-determination and a move towards strengths-based framing, recognising the resilience, the strength and the power of a culture that has existed for thousands of generations, which I think is a fantastically positive perspective to take. That's it.
Thank you so much, Kami. That's a very disturbing picture, but at the same time, really important timing for Indigenous people in Australia. So now we can move to Naeem.
Yeah, thank you for that, Kami. So with respect to my community, or I would like to speak to the wider landscape of Zambia, I'd like to take us back to the basics, really going back, because when we look at health, we can't look at mental health without looking at the whole health perspective. And mental health in Zambia in communities is given very low priority from community level as well as from leadership level. Although this is changing, countries such as Zambia are still confronted with so many problems caused by, communicable infectious diseases and, nutritional challenges that we have not woken up to the impact of mental disorders which we experience. So, Kami's beautifully put out so many statistics, which I do not have because we don't have the opportunity to actually go out and do this because of so many other competing needs that we have in our communities. There's even within the country, as Zambia divided in 10 regions, there's so many regional variations and so many influencing factors and economic conditions that lead to so many cultural attitudes towards mental well-being as well. So when we talk about attitudes towards mental illness, they're still strongly influenced by traditional beliefs, and these also are, intertwined with supernatural causes and remedies. And this belief system often leads to unhelpful or health-damaging responses to mental illness. And this further perpetuates the stigmatization of people living with mental illness or reaching out for support. For individuals that have self-harm or attempt suicide, there's always a delay in seeking appropriate care because of all of these different influencing factors. And then we also come to the education, which is often affected because of these challenges as well. And this leads to, challenges amongst the communities in understanding terminologies such as well-being holistically. Because when you look at well-being holistically, there's that push towards health and mortality, death versus mental illness, which is productivity related. Then we also talk about awareness, which is knowledge that acknowledges culture-specific relevance, which is often not there. Terms such as schizophrenia or depression are not understood in these communities that I work in. Acceptance, because of the stigma that comes with the behavior on certain mental health illnesses, is often perpetuated as the face of mental health. And then finally, access to services. Even where there are services, it does not relate to access to services because of all these different factors that I've highlighted. Thank you.
Thank you so much, Naeem. Yeah, you raise a very interesting point regarding mental health literacy that probably will be raised by other panelists. So now we can move to Mario.
In South America, we as colonized nations in 500 years, colonized continent, we are dispossessed, powerless, voiceless, and oppressed people. In consequence, you can imagine we have nothing concerning mental health service designed or tailored to our communities. There is no single country in South America that offer adapted mental health services to the indigenous people. So that is really quite dramatic. With such neglect, discrimination that you can imagine in this context, historical context of colonization, prejudice, and violence against us, we should be suffering a very bad mental health, right? This massive amount daily of life events of any sort, these social determinants of health, you can anticipate that the mental health is going to be poor. Here, perhaps we can add also the historical determinants of health in order to capture this dimension, this historical dimension that if you are colonized, if you are invaded for centuries, this is going to have a huge impact in physical and mental health. The standard physical and mental health services available in Ecuador, for example, do not consider our languages, our culture, or specific needs. It's just there, and you take it or you leave it. So many indigenous peoples, for this reason, prefer to die at home rather than going to a hospital. The hospitals, clinics, doctors' offices are perceived as hostile places where they could be physically or verbally be abused, disrespected, humiliated, or even killed. It's from this that people, the indigenous peoples over there, don't trust doctors, Western-type doctors. Most of the indigenous people in South America use their traditional medicines instead, and traditional healers are their trusted doctors. We are alive and successfully survived 500 years of brutal European colonialism thanks to our traditional medicines, to our traditional healers, and not Western psychiatry. We don't have mental health services, so the penetration of Western European type psychiatry is not existent. So what we have is our own system of psychiatry and mental health. That is our Inca traditional medicine. Yeah.
Thank you so much, Mario, and for raising again the impacts of colonization on mental health and then intersection with the indigenous people care. We now can move to Raj.
So it's tough to follow Mario, and I think I echo a lot of the sentiments that he spoke about. And in my context, so I'll talk about South Asia. The ideas of caste, class, ethnicity, gender, sexuality, ability, and religion play a very pivotal role in determining the daily stressors people face, exposures and susceptibility to mental ill health, and also then in the services and networks that a person can access, both in terms of mental health support, as well as wider supports, and finally also in the quality of care and support received. Now, all of these consequences interlock and perpetuate the system and situation for those who are marginalized and create a vicious cycle. So what am I trying to say here? Basically that in South Asia, what I call structural barriers such as gender, ability, caste, religion, etc., and systemic barriers decisively affect an individual's well-being. Now, I love examples, so I'll give you an example. In 2021, there was a study which said that 230 million Indians were pushed into poverty. Now, other than meaning unemployment, loss of income, food insecurity, and homelessness, these are also major factors and risk factors for both mental and physical health. There's distress, anxiety, shame, powerlessness, guilt, as well as a higher probability of mental illness and non-communicable disease. And there are similar interlinkages between poverty, homelessness, and mental illness. Does everyone face this equally? No. We know that women who are homeless, of course, are more vulnerable to sexual assault and gender-based violence. However, looking at how mental health is done in the country and larger dominant paradigms around mental health, we don't pick up along the fault lines of caste, gender, and disability. So usually trans women, Dalit women, Adivasi or tribal women, sex workers, and women with disabilities don't have the services that they need and continue to face multiple marginalizations. Thus, in my context, I want to say that mental health issues cannot be considered in isolation from other areas of development, such as education, employment, emergency response, and human rights. And of course, this comes with the understanding that it is not enough to provide mental health services. It is actually imperative to provide linkages when we are providing mental health services to other types of services that support livelihoods, shelter, and social inclusion. So in this context, again, I want to say that mental health is a development issue. It's an issue of inclusion, and it's a very critical path to addressing inequalities, especially in the South Asian context. Thank you.
Thank you so much, Raj. Hopefully, later on we'll be able to expand on those structural barriers that you have mentioned. That's very interesting. And finally, we move to Victoria.
Thank you. Well, here in the US, I want to acknowledge that we have 574 tribal nations who are extremely diverse in worldviews, values, languages, geographies, and cultures. And though our communities are very diverse, we share some commonalities. For example, many tribes view wellness as the interconnected balance across physical, mental, emotional, and spiritual health. And well-being is also related to connections to ancestors, families, communities, lands, identity, and cultural practices and traditions. However, many of these worldviews, values, and traditions were disrupted by settler colonialism through physical genocide, land dispossession, and forced cultural assimilation of indigenous peoples. The impacts and traumas from these experiences can be passed down from generation to generation, what's known as historical trauma or intergenerational trauma. And there's empirical research showing that historical trauma stemming from such events and others are indeed still impacting generations of American Indians and Alaska Natives today, and are linked to outcomes such as depression and anxiety symptoms, substance use, and suicide-related outcomes. When it comes to understanding mental health inequities, it's really important to remember that diversity across communities that I began with. So, for example, suicide rates across American Indian and Alaska Native communities are higher across the United States compared to every other racial and ethnic group in the United States. However, aggregated data don't tell us anything about suicide rates at the community level. So some tribes have low or zero suicides, some have the same rates as the general population, and other tribes have disproportionately high rates of suicide. So we can't just look at national data and assume that all Native communities experience high rates of suicide given that diversity. In addition, mental health inequities we see within some communities are perpetuated by a significant and ongoing shortage of accessible, effective, and culturally informed mental health services. One thing to point out is that tribal nations are sovereign entities with a unique political relationship with the United States federal government that dates back to the signing of hundreds of treaties with tribal nations. The US federal government has a trust responsibility that includes provision of healthcare for tribal members. However, the Indian Health Service has suffered and continues to suffer from chronic underfunding and is not sufficient to cover all American Indians and Alaska Natives in the United States, which perpetuates mental health inequities. So in conclusion, I just want to summarize again, our tribal nations are extremely diverse. Similarly, mental health inequities differ very much by community and are rooted in settler colonialism and its lasting impacts today. And finally, and importantly, our communities continue to pass on cultural strengths that we've always held since time immemorial, including our worldviews and teachings around holistic and balanced views of physical, mental, emotional, and spiritual health. Thank you.
Thank you so much, Victoria. Yeah, colonization seems to be a recurring theme across all the what has been said by all panelists. So I was wondering if any of you wants to comment on anything that has been said, like we have a minute or two to do that. Otherwise, we can move to the second question. Soph, over to you.
Thanks, Anna, and thanks everyone for your questions on the first round. That's already a lot to think about. And so we have a sense of these different situations that you're all in and talking about. And even as you've summarized those, you've all mentioned these historical dimensions and structural and systemic issues. And in this second question that we would love you to talk to, we wanted to go a bit further in that more sort of conceptual direction and hear about any challenges or tensions between local and indigenous understandings and the sort of dominant mental health narratives. And then building on that, as most of you have mentioned colonization already, it fits because we'd love to hear your thoughts on the idea of decolonizing mental health, what decolonization might mean to you, whether it's relevant, constructive, wanted. So we'll stick with the same order for your answers to keep it simple. So we'll start again with you, Cami.
Thank you, Soph. I think, let me just swap across here. I really echo that the similarities we see in each of these contexts are not just the similarities of challenges of colonization, but there is also a very similar thread in terms of what Indigenous peoples perceive as mental health or rather well-being. And we just heard Victoria explain how First Nations peoples across America kind of perceive well-being through a few different facets. And in Australia, Aboriginal and Torres Strait Islander psychologists developed this lovely model of social and emotional well-being that I've got up on the screen here, this wheel. And this talks about well-being as an interconnected and holistic concept where we integrate ideas of physical well-being, of mental well-being, family, kinship, community, culture, land, and spirituality. And the way that we talk about this within communities is that to achieve well-being, to achieve a sense of well-being, you need to have a connection with each of these different facets. But often, and due to a variety of different determinants that others have already mentioned, social, political, cultural, these connections have been disrupted, primarily through colonization. And so what happens when we work in a system where, you know, mainstream mental health services are really siloed, there is a really ingrained systematic mismatch between the priorities, perspectives, and approaches that are applied in our healthcare systems and the ways that people understand and live their well-being. And we see this in similar to what others have mentioned, that services just don't cater to the needs of Indigenous peoples. But likewise, I think non-Indigenous communities are also beginning to recognise that a siloed approach to health and to mental health is not achieving what we want it to achieve. And that perhaps we frame it as decolonisation, perhaps we frame it in a different way, but deconstructing the systems of power and privilege that have built these healthcare systems is going to go a lot further towards contributing to people's sense of wellness. Seeing things like self-determination at the forefront and addressing disconnections that we spoke about, disconnection from the land, where we can come back to the land and say, you know, let's care for the land, because the health of Mother Earth is so related to the health of our well-being. We actually need to see them as one and the same. Addressing the influence of capitalism, how that plays out, and then switching it and looking at the things that Indigenous peoples have used to promote well-being. So valuing and promoting and integrating, you know, the lived human experience with spirituality, with community, and with ecology. I think those things are going to contribute a lot to improving broadly the well-being of people. But I'm not sure if it's called colonisation or maybe it's called something else. And I think the situation, particularly we've seen in the last week with Israel and Palestine, and I don't want to go into politics here, but there is discussion about what is decolonisation. So, yeah.
Thanks so much, Cami. Yeah, again, it's a lot to think about. Let's move over now to Naeem again. Over to you.
Yeah. So the challenges that I'd like to frame on the dominant narratives in global mental health and looking at the local understandings, I'm going to bring a perspective from my experience as, having been brought up in this community and then going through life in my social exposures, going through medical school, which is dominantly, Eurocentric, and also getting evidence-based from, North American and European studies. And then going through my Masters of Medicine, where majority of the treatment guidelines as well as the diagnostic criteria are being, the evidence is actually coming from the Northern as well as not Eurocentric perspectives. And one of the key challenges is the lack of the important consideration in the narratives where the close relation between the level of mental health in the community and that of the general level of social well-being. Mental health narratives need to recognize and stress the importance of other areas of social services and health services, which have strong implications for mental health. Concerns and issues relating to unemployment, homelessness amongst people in communities, and the levels of poverty are important in looking at mental health and framing mental illness and mental disorders. And I say this because going through my education as a psychiatrist, oftentimes looking at constructs as delusions and hallucinations and looking at the beliefs and the values towards religion were often not looked at holistically. And you're just looking at this criteria and saying, oh yes, you meet this criteria. You've been feeling low for so long. So clearly this is where you fit. However, not looking at the fact that this is a person that is coming from a community where socially it has always been accepted for that person to maybe take a certain substance. And that's a social norm that has been accepted. Then why is it that we're going on and labeling this person? In addition to that, looking at concepts and constructs such as the correlation of other health issues. The world saw COVID-19 fully. In a country like Zambia, we've been having HIV and AIDS, the pandemic of HIV and AIDS for so long. And there's been that correlation between that and mental well-being and mental ill health. And that has also been a challenge because a person living with HIV, it will come through and we'll be very quick to diagnose them with a mental illness, not looking at the precursors and the risk factors that these individuals have actually been exposed to. And also looking at the rehabilitation of mentally ill people and the acceptance from the wider community, because of the lack of, understanding around how mental health is supposed to be framed. And I'd like to just bring in the point of, decolonization, not just from that perspective, but looking at it from a lens of, the community, and being able to understand what is it that the person that we're helping will relate to. And this also has to do with, discrimination that was raised by Mario. You will find, I actually found myself as a healthcare worker, as a mental health specialist at the tertiary hospital, discriminating against the people that were coming to care, because I was looking at the education system that I was exposed to. And I was like, that is the right thing. That is the gold standard. That is the evidence base. But in actual fact, that is not what is going to be related, and that doesn't apply. There were times when I was actually questioning whether I know what I'm doing. In theory, everything makes sense to me. I'll get my grade. But in actual practice, these things are not really making sense. So is that something wrong as a healthcare worker? Am I doing something wrong? Am I wrong? So decolonization from that perspective is what I'd like to bring up, to say we also have to look at the education systems of healthcare workers to overcome this discrimination that we actually see. Thank you.
Thank you so much, Naeem. It sounds disorienting, the different perspectives being held at once. Let's move over to Mario again now.
I would like to highlight 3 issues around this question. The first is, well, for us, is how to help Western psychiatry be less, let's say, Western-centric, universalist, and how to decrease among physicians, among mental health workers, this kind of arrogance. Sometimes we call this in health, in medicine, supremacy of Western medicine. Well, let me give you an example, and then perhaps it's clearer how I'm trying to say. You know, in South America, we are 30 million indigenous people. We are a huge population. It's almost the size of Canada, right? Or the state of New York. And then most of these people are monolinguals. More and more we have bilinguals. Quechua language, for example, and Spanish. Spanish is the dominant language in South America. Well, mental health workers rarely speak an indigenous language. You see now, 30 million people, let's say half are monolingual, Quechua-speaking people. How they are going to communicate with mental health workers who speak only Spanish? And they are convinced that the ideas of causation, the treatment preferences, or the profile of symptoms that they are going to find among the indigenous communities are the same as they see in textbooks. These textbooks are prepared according to research and experiences of wonderful physicians in Europe and North America. Yeah, that's right. But it doesn't really fit quite well when you are trying to apply all these ideas with the indigenous people. The indigenous people, for example, will give priority to spirits, the harmonious interaction with spirits that you can find in nature, in the rocks, lakes, animals, and people, humans. And this is rarely taken into consideration on the nosology or etiology of Western psychiatry, for example. Well, this is the kind of problems that we have, how to make Western psychiatry less universalist, more sensitive to local cultures. The second point is how to help to make Western-based mental health programs more accommodating to Western knowledge and indigenous mental health strategies is related to the first part. Yeah, I think maybe it's education that is going to help. The education on Western type mental health workers, making them more sensitive to social issues, to cultural issues. And then we can have more well-prepared workforce in the nation. And just asking to have more indigenous people who are trained in medicine, in Western medicine, is not enough also. Because imagine, in my own case, I'm the very first physician who graduated from a medical school in Ecuador. Now, 30 years later, we have only 5 more physicians in the entire country. And we are almost 7 million in Ecuador. So for 7 million, we have 6 physicians. And I'm the only psychiatrist, Quechua-speaking psychiatrist in Ecuador. So inviting the Quechua people to go to medicine and become mental health workers is not feasible, really. And quickly is to propose and fund effective collaboration between Western psychiatry and indigenous psychiatry for the betterment
Thank you so
of
much,
the...
Mario. I'll just interrupt you there, just so that we make sure we have time for all of our speakers. Perhaps you can expand on your third point later. But for now, let's move over to Raj again.
So I think before I answer this question, I think all the speakers have spoken about or defined what the margins are, what the oppressed are, but we rarely ever define the default or the normative, and that is Western. Some people are calling it Western, I call it Eurocentric, because usually it means a gaze that is white, able-bodied, cis, heteronormative, male gaze. And this particular gaze or approach has a disproportionate power in shaping the global mental health agenda. And of course, with it comes the assumption that mental health concerns and their impact are standardizable across the globe. And this dominates both academia, practice, and research. And I'm going to reframe that idea of a challenge, because I don't think it's a challenge. I think it's a systemic failure. And it is a systemic failure because this gaze is incomplete and harmful. Because yes, we spoke about the historical legacies of colonization, but we must realize that a lot of our mental health systems still uphold this type of structural violence and oppression. So I'll give an example. If we look at climate change and mental health, a lot of climate change is also Eurocentric and individualized, just like global mental health discourse, not talking about communities, not talking about families, but about individuals, individual prescriptions. Now, this can be harmful and further marginalize, for example, indigenous communities. And I think neither field recognizes the fact that indigenous communities inhabit 22% of the Earth's surface and yet protect and care for 80% of the Earth's biodiversity. Instead, what we tend to hear a whole lot more is indigenous communities, especially in India, we'll hear about substance dependency or suicide. But what about the ways of coping with loss of land and grief of losing ways of life? And it's perhaps also why our mental health systems and other systems don't value things like taking an approach to mental health that looks at both biodiversity and human life together. In fact, the more papers you'll read, you'll find that the value of biodiversity and of human health and life is referred to as a non-market impact. Now, if we flip this paradigm, 2022 figures said that poor mental health had estimated costs and reduced productivity of about 6 trillion by 2030. So we have inbuilt oppression and inbuilt structural violence and ableism in mental health. And I think that's why we continue to have these challenges or disconnects. And instead of foregrounding the idea that our well-being and mental health are tied to that of our ecosystems, and we must actually challenge structural inequality, counter systems of privilege and power in order to build solidarity and allyship if we are to do global mental health differently. Thank you.
Thank you very much. Yeah, very powerful messages Cami has put in our chat, and I would just like to say the same thing from everybody all around. Let's hear now on this point from Victoria as well. Over to you, Victoria.
Thank you. And I really like what Raj just said about how these challenges are that word, maybe systemic is the more accurate word, they're intentional, and I really agree with that. What I want to address is the perpetuation by dominant and Eurocentric narratives in global mental health focus on an individual's mental health symptoms and distress. And, you know, this is echoed by some of the other panelists, but in particular for American Indian and Alaska Native communities in the United States, as I mentioned earlier, mental health is inseparable from physical, emotional, and spiritual health. And mental health is not just about the mind, it's about the body, it's about emotions, spirit, heart, family, community, culture, ancestors, connections to lands, all other beings, and the cosmos. And each tribe continues to carry forward their unique worldviews, values, and understandings about the mind, mental health, and well-being. Therefore, this focus on symptoms and distress and individualized treatment that dominates in global health and global mental health conflicts with understandings of many American Indian and Alaska Native communities' health, mental health, and wellness that is interconnected with so many other aspects of life well beyond the individual. Therefore, when we talk about decolonization of mental health, it requires moving away from deficit, pathology, symptoms, distress, and instead requires being responsive towards all areas of well-being and really being driven by local communities and their worldviews, values, and cultures. And within Indigenous communities here in the United States, there's so many examples of community-led programming that promote tribal worldviews, values, and traditions. Some of these examples include community programs that promote tribal language learning, culture camps, family and community gatherings, connecting youth and elders together, ceremonies, cultural activities, and protection of Indigenous lands that are so vital and tied to health, mental health, and well-being for many Indigenous communities, very similar to what Cami shared earlier. And overall, these community, culturally, and land-based approaches inherently address historical, social, and political contexts that are often absent from Eurocentric narratives in global mental health and promote self-determination around Indigenous mental health and overall well-being, and again, work towards decolonizing mental health. Thank you.
Thank you. And I love that in all of your, or some definitely of your answers to this question, you're already anticipating our next question in the way you're seeing ways that we could move forward. So I'll hand back over to Anna to think about the next question that we wanted to pose.
Yeah, so we mostly have been discussing the different challenges. So as Soph said, it's good to now focus on the way forward. So this question is more related to which kind of initiatives you think should be implemented to prioritize local understanding in mental health care. And some of you have touched upon this while answering the last question, but maybe you could expand on some of the points you've started discussing. So we start again with Cami.
Thank you, Anna. I mean, future directions is huge, and there is always a lot of, you know, the ideal and the end point. But I think for right now, we are in a state in the world where there is so much turmoil around us. There is political conflict, there is climate change, there is, you know, soaring rates of mental illness. we need to do something right now, even if it isn't achieving the perfect end goal that we might hope for. And the way I think about this is that we need to transform how we relate, govern and distribute resources. A lot of the panelists have spoken about, and it is similar in Australia, that there aren't enough resources, systems or practitioners doing things in a way that reflects a culturally responsive mental health care. And I think part of this requires us to address the inequities that have caused us to be in this situation, address inequities through processes like truth-telling, reparations and self-determination. But fundamentally, it does go back to what Naeem was saying and what Raj was saying about how we frame these systems. Indigenous people know what works for us. We are still existing because we know what works for us. However, we are not often given the opportunities to practice. And one of the things that I think Eurocentric and Western healthcare in particular can really learn from is reframing these into a strengths-based approach, moving away from that over-reliance and the framed superiority of Western and Eurocentric biomedical systems. You know, that idea that things are a problem, there are diagnostics, measurements, treatments, it's all about a deficit. When I think maybe we need to reframe things as some of these mental illnesses that people are diagnosed with are actually a perfectly healthy response to the situation that people are being forced into. If we think about the example that was given before of climate change, I would argue that climate anxiety, which people are starting to talk about as a formal diagnosis, that's a perfectly healthy response to what is going on in our world right now. Likewise, responses that are highly political, people see people that are being angry, anger can be very appropriate responses to recognizing the power imbalances and this turmoil of the world that we live in. So I think things like moving towards recognizing the sustainability, power and potential of Indigenous and First Nations ways of knowing, being and doing can help us in that transformation. And when it comes down to individual actions, one of the things that I teach my students is this should not be the responsibility of Indigenous peoples to solve the problems. There is a role of active allyship for everyone, but what it requires is really vulnerable self-reflection. It requires practitioners to go back and look at where their foundations of knowledge come from, where their practice comes from, and perhaps dismantle that a little bit. Understand why they believe what they believe, understand, you know, who determined the theories that you believe and you practice. Is it, you know, normal and healthy because it came from a Western or Eurocentric perspective, or is that just the perspective that it came from, being defined by able-bodied, white, wealthy communities? If we can flip that and focus on the things that Indigenous people value, we can radically and honestly confront racism and discrimination and oppression and white privilege. There are two sides of the coin here. Others have already mentioned maybe thinking about this from a community perspective and turning our gaze towards the values that we can all see that are driving the concerns we have now, such as climate change. And, you know, maybe we go back to community and protecting Mother Earth and protecting well-being as a holistic perspective. Thank you.
Thank you so much, Cami. Yeah, that's very interesting, the questioning what is mental health and well-being and reframing it. So now we move to Naeem to also give us his thoughts on this question.
Yeah, yes, Kami, that's the comment I just read from Raj, and I was just echoing that in my mind as well on the point of perfectly healthy response. And this is exactly where the future directions that I see in mental health and well-being looking at all of these things that, communities that are not Western or Eurocentric face, they face different experiences in their day-to-day lives. And based on these experiences, these are perfectly healthy responses. This has always been my tagline. The labels of diagnosis around mental health and mental illness really need to be reframed. And I look at it as on the concept of research as well. Global mental health frameworks have to be fluid and flexible, and they really have to look at the concept of co-production. Co-production meaning that you're co-designing and co-creating these interventions with these communities in mind, not just having them as a checkbox at the table, but really having them understand what their role is at the table and what they can do, and empower them to be able to support these interventions. In addition to that, looking at the whole concept of implementation research. I know the slide probably has an error, but implementation research is very key, not just having research looking at what is the answer to bridging the gap between the findings and the real world practice, because arguably majority of the global mental health research has not yet been implemented, has not influenced policy, has not been able to communicate what is it that those interventions are able to do. So having an implementation perspective around communities and being able to support those communities, I would actually also say and lobby and advocate that research should have a percentage of their funding and their budget going to implementing as well as sustaining that particular intervention that works beyond the actual research outcome base. In addition to that, looking at inclusivity, right now, global mental health is infinite. And this is very clear from this just discussion that we've had. Even within Zambia, in different regions, no two places actually experience the same level of certain symptoms that we actually discuss. And then promoting context-specific funding calls. Again, bringing back to the buzzword right now around climate change and mental health, there's this discussion around anxiety and depression because of climate change and what that is doing. Is that context-specific to different communities? Because again, that is just very vague, just saying climate change and mental health, what is the link? Let's talk about this holistically, as Kami has put it. It's a perfectly healthy response. And I'd just like to give you an anecdote and an example from Zambia here, where we are actually seeing a lot of people migrating from urban areas to rural areas because of the climate uncertainty that they're experiencing, looking for opportunities to thrive. And what does that mean? Does that really apply to that funding call that is talking about anxiety? So these are things that really need to look at context-specific funding calls as well. And of course, frameworks have to be in progress, be able, not just be very formal, be able to, have a dynamic and evolving guide, because we're not going to get the answers. As Kami said, we may not be able to do everything right now, but being able to put up the framework that is evolving. Thank you.
Thank you so much, Naheem. Yeah, that the need for co-production, it's really important in ensuring that context and culture is included in mental health interventions. So now we can move to Mario.
Well, for the future, we see one path, and that is the collaboration between Western psychiatry and traditional medicine in South America. What means this collaboration? Is working together, really, the traditional healers and others, specialists in the traditional system, and mental health workers. That's exactly what we did almost 25 years ago. A project, a unique project in all Latin America, really, called Ambiguasi, where traditional healers and Western trained doctors were working together, sharing the same physical space and receiving patients and evaluating patients together and looking for a treatment plan together. This was accepted wonderfully by the Quechua Inca community in Ecuador. The problem is that because we don't have control over the resources in the country, the politics, I mean, so was always difficult to fund this project. Fortunately, the United Nations decided to fund this project and now is working with the help of the United Nations. So this type of collaboration, I think, is essential for the future. The widespread neglect of the indigenous people's mental health in South America is nothing short of a scandal and immorality. We are starting to see this problem as an immorality, as Professor Clement at Harvard, talking about mental health in general, said that we don't need more research. What we need is to make a moral case. So we think that we need to continue to make a moral case about the condition of the indigenous people in South America. And hopefully governments, academicians, medical journals will give more attention to the mental health status of the indigenous people. We are the first inhabitants of the Americas, and yet we continue to be the most neglected and marginalized group on the continent. And we have no mental health services. Look, the immorality here. Another idea that we have is that we need to go beyond the standards of care and rather try to integrate the modern ideas of a medicine that is going to be person-centered, a medicine that is going to be more precise. So I'm talking about these modern ideas about precision psychiatry, for example, and personalized psychiatry. If we do that, perhaps we can do good things, create good projects for the future. And another thing for finishing is the great contribution of modern digital health technology. This is something that we are very optimistic about because it could help democratize the access to mental health care. These health apps that are developing, and we are participating in one specifically, capable of identifying anxiety, depression, post-traumatic stress disorder, and addiction, is able to even follow up patients and provide some basic psychotherapy. If we do this, we are giving more access to the indigenous people. In addition, we are going to bypass some racist, biased mental health professionals who don't speak Spanish. These apps or the medicine, online medicine, could help bypass really all these problems, and we can have a good access to mental health. I hope I have some time.
Yes.
I was thinking perhaps in questions, I can give some examples of other technological advances that help it in this way, like banking or the telephone in Ecuador. Thank you.
Yeah, we can then explore that in the Q&A. Thank you so much, Mari. So now we can move to Victoria. To Raj.
So I think, I feel a lot of resonance with what everyone has said, but I did want to echo Cami and say that at this point, I feel like mainstream mental health or the side disciplines really risk pathologizing and individualizing the distress that results from, and I must call this out, the violence of neoliberal extractivism and settler colonialism that we still practice. And historically, if we continue to place the responsibility for distress on individuals, we are obfuscating certain systems of power and also societal suffering. So, I mean, I think the idea is that we must recognize that there's a crisis of care, not of treatment, but a crisis of care. And the idea that mental health interventions are either talk therapy or psychiatry in different forms is also very much related to dominant understandings of mental health and individual understandings of mental health. So we really actually need to move beyond these mainstream ideas. And the idea then is how do we look at, straddling this binary, and all binaries are reductive in that sense, of global and local, and not as a zero-sum game, but really as a set of practices that can traverse cultural idioms of distress, collective and shared ways of experiencing, engaging with community knowledge, and of course, sidestepping the idea that mental health is based only on access to certain languages. And I think for that, really, mental health work needs to go beyond just cognitive appraisals and really work towards the idea of what I'm calling psychosocial justice, which means network building of tangible avenues towards employment, housing, food security for uprooted communities, different approaches to conflict zones, disaster areas, refugee resettlement. And we really need to think about redefining goals of empowerment as a sustained process and not as a short-term product. And for that, I really want to call for navigating mental health and building affirmative lenses that are informed by knowledge and lived experience from the margins, understanding of class and caste inequalities, historical uprootings, generational loss, colonial history, anti-racist work, and of course, gender as well. I think the question for me is, what are the multiplicity of ways in which we can engage with healing from traumas of structural violence, structural injustice, especially as trauma can be a conflicted, difficult, painful process, and also a political act. And for me, part of the answer really lies in counter-narratives of structurally oppressed communities that are at the heart of learning and to be seen as valid producers of knowledge. So I think I'll end with saying that this is a call for engagement with knowledge of marginalized communities, values, and their resources in developing the field of psi disciplines.
Thank you so much, Raj. Yeah, that concept that psychosocial justice is really relevant here. So finally, we can move to Victoria.
Thank you, Anna. What I want to focus on is really talking about increasing Indigenous visibility and representation, which will inherently prioritize local and Indigenous understandings. So within the United States, we continue to experience invisibility in multiple areas of society, which can perpetuate non-Indigenous people not thinking about our communities. And at the same time, it can also perpetuate non-Indigenous people relying on false narratives or stereotypes about our peoples if they're not seeing us in their day-to-day lives and knowing that we are still here. So it's important to increase visibility and representation of Indigenous peoples throughout society, as well as in the mental health fields. So we need to ensure, for example, within mental health, that training, which includes both classes and clinical training, includes didactic and case examples about Indigenous communities. This will help educate non-Indigenous students or trainees about our community's understandings and solutions around mental health. At the same time, it will also provide an environment where Indigenous students can see themselves represented and not feel invisible. This can also expose students and trainees to community-based participatory research or Indigenous research methodologies, as well as community-led programming and community solutions to addressing mental health and overall well-being. A second initiative related to representation is increasing our American Indian and Alaska Native workforce to increase accessibility to culturally informed mental health care. So we need more pathway programs in high schools and universities to increase our representation within these fields, and also know that by having our people in these fields, we're bringing our tribal values, worldviews, and traditions to our work. I was a part of a program like this called American Indians into Psychology. This was a really vital path for me to graduate school as my career. We also need funding and support to increase community mental health workers and behavioral health aides. So local community mental health workers are from a particular community, and therefore they may have understandings of history, culture, traditional views of health and wellness that may reduce barriers to care. They also have specific roles and responsibilities and don't require long training and professional degrees, which is often the case in PhDs or medical degrees. They can provide tremendous support to community members and can help reduce mental health inequities that may be experienced. Also, we need more funding and support and access to traditional healing that may be preferred by tribal community members. And to conclude, I just want to again say that representation will ensure that we won't be invisible from society in all areas of society, but also in mental health. It ensures that we'll have increased presence in community-based and professionally based mental health areas, which can help reduce inequities. And by having representation, we have a path for Indigenous voices, Indigenous leadership, as well as our worldviews, frameworks, methodologies, and solutions to be included in mental health. We have so many innovative solutions, and I just want to end by saying Indigenous peoples have so much to teach the world about mental health, being part of holistic health and well-being, as well as so many approaches to mental health and well-being that are led by our communities worldwide. Thank you.
Thank you so much, Victor. We actually had a question from the audience directed to you about representation and training, so you've answered that one already. So before moving to the Q&A, I would like to ask whether you want to comment on anything that has just been said. Otherwise, we can move to the Q&A. So I think, Soph, you will kick us off with the Q&A, right?
Yes, absolutely. And I love that note that you ended on there, Victoria, was that Indigenous communities and peoples have so much to teach. This is precisely why we wanted you all to talk. So there's a few questions that have come through. I wanted to start off with one. It kind of picks up from the question that you were all just answering, and it's from Megan McLaren, and it's saying, with everything that you speakers have said so far, what recommendations would you have specifically for designing communications campaigns or self-help interventions, like outside of the health service? In a way, you've answered some of that already, but would any of you like to expand on that question? Just unmute yourself and speak up if you would like to. Just jump in.
Yeah, I'll go first, just to guide. So with the particular question is focusing on, designing communication campaigns or self-help intervention. So right now we're currently doing something in a community in Zambia, which is very rural and remote. And the most support that they have, they don't even have the privilege of electricity per se, but they have, speakers that work as radios, double as radios, kind of like walkie-talkies. And so we had to go, first of all, when you're designing these community campaigns, you have to go in the community and understand what is their way of life, what is their social structure, and how they look at well-being and mental health. What do they understand by that? And then correlate that to their needs around mental health and well-being. And this really helps looking at the various factors that go into communities. In a context like Zambia, we have a huge spiritual well-being sector, which is also kind of mixed with the secular religion. Zambia being a Christian nation, so trying to embed all of that into the campaign would really work on that. One of the key points that we found challenging, and which was very interesting to note, was when you don't identify a stressor, for instance, something bad has happened in a person's life, they're not able to correlate it to a mental health symptom. So you always have to start by saying, oh, this person went through a bad experience and that is why they are feeling this way, which is what the campaign was trying to promote. But that was not the truth, because the community communicated back and said, we don't always look at bad things to do with bad experiences. We also internally feel bad at times to do with our well-being and our environment. And, you know, if that's just how we feel. So to answer that question, you really need to do your groundwork and go to that community and help carry out an understanding, a situational analysis to understand what that community understands, and not really look at it from the circular mental health symptoms checklist. Thank you.
Thanks, Naeem. Does anybody else want to jump in on that before we go to another question?
I have a little bit of a perspective on this. This is exactly some of the work that I'm doing in my research. Currently, we're exploring what are the tangible practices that we can articulate, particularly to young people who are experiencing some of the disconnections that I spoke about before regarding well-being. And one of the things that I've found is that these young people who are experiencing distress of some kind are often minimizing strategies that they already have to improve their well-being. And so, for example, I had one young woman express to me that she had relocated for work, and she was living in a city that felt different. She felt disconnected from her traditional lands. And on her way to work, she walked to work through what she described as a concrete jungle. She grabbed a gum leaf, which is a spiritual and sacred object within our community. She scrunched it up, and it has the smell of eucalyptus. And after she told me this story, she told me, you know, don't worry about that. That's just, I felt a bit silly. That doesn't really mean anything. And I had to tell her, you know what? These small little practices that we have can build to be something fulfilling, can build to be something that actually articulates and connects you to your well-being, to your spirituality, to your culture, and to your community, things that are intrinsically important to who you are. So do not minimize these strategies that you already have, no matter how they might be framed by other communities and other people. So sometimes I think it's about, maybe we don't have to tackle these things with big programs, with big initiatives, with diagnostics, with medications. Sometimes the communities already have even these small little strategies, little parts of their day. We just need to be able to articulate that those are valuable resources that people already have.
That's great. And it comes back to what you've said, what various of you have said already about looking at strengths-based, looking at resources rather than being focused on this deficit approach and looking at problems. Even though you've just said, let's not focus on the big picture, I wondered if we could go to a next question that is quite about big picture. But Anna, do you want to ask a next question, or can I go to the next one?
I have a very practical one from the audience. There is a psychologist who says has become disillusioned with the mental health system and individual focus of treatment with little consideration of social determinants of health, and is now asking for some practical advice, of which I'm sure others are seeking for, which is how to continue a career in mental health treatment without participating in and contributing to the perpetuation of the current narrow, racist, and discriminatory system. So this person ends by saying, how can I, as a clinician, help from inside the system, which I thought was a very interesting, nice way to end the question. So does any of you would like to answer this question?
I'm happy to start. I think one, sorry. I was going to say, I think it's really important for clinicians who are in this system to, I think, attend to so many of what so many of us have shared on this panel about really understanding local culture, community, environment, political situation, depending on where you're at and with the person that you're working with. But I think it's really important to also really understand, again, I think many of us have talked about mental health solutions outside of a hospital, outside of a clinical setting, and really understanding what are, how does a community define mental health? Is it holistic? Is it part of other pieces of health? Is it related to land? Is it related to community and family and culture? And just really understanding. And I think that understanding is going to come both from the person that you're working with, but also I think it's really the responsibility of all clinicians to also learn about communities. And you're not always going to get all of that from a book or videos or training. I think you have to really continually educate yourself and practice cultural humility over cultural competence, because that's not something you can just check off the box. You have to continually learn, and there's not an end to that. So it's really also being understanding and educating yourself about what's happening outside of the system and what are the resources and supports of care that individuals have and may be seeking or wanting to seek, and being supportive of that as well. Thank you.
Thank you so much, Victoria. Nahim, I think you were also going to say something about it.
Yes, I actually agree with Victoria on understanding. That's the key point. And also knowing that these things are not going to be found in textbooks. You really need to make that effort as a clinician or a healthcare worker in mental health when you're working with indigenous communities or generally communities that are not in line with the standard Eurocentric or Western lifestyles. And that is very, very key to understand, because I found myself in that space a lot, and many times it was very overwhelming because as a clinician, I want to know what's right and I want to do right by the my clients and my patients, but then the answers are not there. So this is where you have to evoke the concerns and concepts of shared decision making with your clients and helping them understand as well. At times, it also kind of becomes very tricky, and it tends to be very hard on you as a healthcare worker, because clients come to you for help and they want the answers, and then they want you to give those answers. And then when you actually bring in the concept of shared decision making, sometimes they become overwhelmed and they say, oh, you also don't know how to help me and I don't know what to do about it. So how do I go from there? So it's a bit tricky, but at the same time, as Victoria has highlighted, really understanding communities, really trying to figure out and getting to understand how to help them would really go a long way.
If I may also quickly jump in to address this question, do we have time?
Of course.
So I want to say that it's very important in a more tangible way to center and learn from the lived experiences of the margins if one is to do things differently. And part of that is really looking at how the psi disciplines themselves collude in oppression, because we know from the colonial history, etc., because it was never about disease, it was more about social order and disciplining certain types of bodies and minds. And so I think moving towards an anti-oppressive framework to challenge systems that are unequal, to queer mental health, to kind of challenge ableism in mental health or racism in mental health, and look at it as a social justice issue, but I think also for clinicians, honestly, to do continuous allyship with marginalized communities, individuals, and identities is very critical, and to move beyond just doing allyship in a clinical setting to actually legal and other types of settings and doing advocacy. So yeah, that's all I wanted to say.
Thank you so much, Raj. I guess, Soph, you can take us to the final Q&A question.
We'll do one question. We basically only have less than a minute left. It maybe that you have to do one-word answers to the question, but I had referenced before that I was interested to go back to the big picture level. So there's a question about how you all see the future of global health, especially considering the dominance of Western supremacy and Eurocentric movements towards mental health. So it's about, is there a need for some universality? The question goes on, but I'm going to stop there. And if any of you has like a very snappy answer, it's a huge question, but if anyone has a snappy thought, that would be lovely.
I had a quick thought, snappy. What we need is to realign our values of humanity with the way we practice healthcare. That's it. We've gotten out of alignment and we need to come back to what those values are, whether they are global values or they are localized values. That is where we've stepped off the path. And I think realigning those values will get us back on track at least.
That sounds good. Does anyone want to add a final thing before we start to wrap up? No. Well, I honestly could continue this discussion for hours. I love hearing from you all. I've learned so much. I can't even wrap it up. There's too many different things. But I guess the biggest takeaways have been about the need for mutual learning, or like specifically emphasizing a particular direction of learning, which is from this Western side, learning from different Indigenous perspectives, and the value of community and countering this over-individualist approach, the strengths-based approach instead of deficit. That I could go on. I really like the way that in between all your different perspectives, there's been lots of themes that you've echoed from each other and similarities. And that's been really inspiring and energizing and wonderful to hear. But it has to come to an end. For now, we've had a lot of questions in the box, and we will look at them all, we will save them all, and we'll see if we can reply in another way. So don't worry if you didn't get your question answered and you would like to. I hope this discussion inspires more work or action or initiatives among those of you who've attended, and maybe those of us who took part will also keep in touch. I want to say an enormous thank you to all of our speakers for giving up your time at all different time zones, from the very early morning to very late at night. And thank you to all of our participants who've tuned in. And yeah, this will appear. This will be accessible later as an on-demand version if you want to look again or share it with somebody else. So that's it. If you want, you can look through our Lancet Spotlight pages to explore other things beyond this webinar. But for now, I will say thank you again, and until next time.